Hello, friends. We're talking on this topic complications and troubleshooting during ECMO. So, this talk gave it as part of our Manipal ECMO meet that we had on 18th May. So, wish to acknowledge my colleague, Dr. Pradeep, who helped me develop this content. So, the topic that I'll be covering is a bit of a background. So, for all the trainees, it's important to understand and have clarity on the type of complications that one can face in ECMO and what is the literature sort of a numbers with regards to the complications. So the main complications one would expect in ECMO is all the vascular complications and the circuit-related complications. Bleeding is an important complication. So one thing throughout my narrative you would see that the whole complication is trying to having a balance between avoiding bleeding and at the same time avoiding the prothrombotic state. So that is the fine sort of a balance that we need to have when we are dealing with ECMO, because as much as bleeding episodes happen, the same amount of prothrombotic states also can happen. So this is something which I wish to dawn upon. So it is increasingly recognized that ECMO patients have deficiency of one Willebrand factor, and this is something possibly that needs more sort of a deliberation. So one Willebrand factor deficiency as a reason for the ongoing bleeding or as a reason for hemolysis and so on and so forth has been contemplated. Hemolysis is another important complication, and need to recognize this very early on is important to improve the outcome. So these are two areas possibly we can little focus on, and newer sort of an emerging thoughts on this. So neurological complications is something that happens. Differential hypoxemia more happens in VA ECMO, Harlequin syndrome. So I'm sure some of you might have heard. Renal complications and infections is something that are quite common in ECMO, and one needs to have a bit of a clarity on that. And recirculation is one aspect, and summary. So these are the different components that I would be covering. So just to give a pictorial representation of VA ECMO, so you have a blood that is drawn from the venous circulation, gets oxygenated, and oxygenated blood is putting back into the circulation. So in the arterial circulation. So VV ECMO, so you have a venous blood drawn from the femoral vein, and the oxygenated blood after passing through the oxygenator enters the circulation through the jugular vein. So this is VV ECMO. The left one is VA ECMO, where you are sending it back into the arterial circulation. So when you look at the background, so it has been clearly shown that ECMO complications has a direct bearing on the patient outcome. So our whole effort is to minimize complication, because the more complications, more detrimental outcome and increase in the mortality. And the mortality attributed to the complications from the study is around 6.9%. So there was a huge systematic review by the Spanish group that came in 2017, where the attributable mortality due to complications is 6.9%. And as you see, mortality due to bleeding is around 3.0. There were 12 studies that they have looked into, and the 8 studies have looked into mortality due to complications. 7 studies have looked into mortality due to bleeding, which is 3.3%. And if you look at the significant bleeding, which has 9 studies have looked into it, 10.4%. Cannula bleeding is 9.3%. So bleeding literally can happen at any place. It can happen in the intracerebral bleed. It can happen in the airway bleed, pulmonary hemorrhage. But more commonly, most studies show the bleeding typically happens at all the cannulation sites. And the other complications is even the mechanical failure of the machine, the oxygenator failure, that also has a bearing on the mortality. As you see, 12.8%. 2 studies have reported oxygenated failure also. So these are some of the complications which is sort of reference from all the studies. Around 12 studies they have collated, and these are the sort of different complications that can happen. So when we talk about vascular complications, it is cited as the leading cause of mortality in ECMO, and the most dreaded complication, vascular complication, is the ischemic limb, because you're putting big catheters in the vein and the artery. So ischemic limb is something that one has to keep in mind. And this is more common in the VA ECMO, because you're putting a big cannula in the artery. 10 to 70% of them are at a risk of developing ischemic limb in VA ECMO. And very often, the what complication is related to difficulty in cannulation because of narrow vessels. So there could be vascular stenosis, there can be narrowing of the vessels due to the atherosclerosis. All these are some of the reasons for difficult cannulation. Or there may be severe vasospasm, which also may be one of the reasons for difficult cannulation. And lack of pulsatility flow, especially in the cardiac arrest situation. So difficult cannulation is something that is common. And the vessel size may be smaller in female gender. That also can be a reason for difficult cannulation. Or there can be anatomical aberration or anatomical variation, which is also one of the reasons for difficult cannulation, and obesity. And many often the size of the cannula can be larger than the vessel. So ideally, the size of the cannula should be around two-thirds or less than that of the vascular circumference. So if it is more than two-thirds, so there may be difficulty in cannulation the vessels. So if you are especially taking a cannula which is bigger size, more than 20 French, and the vessel size is smaller, so that also may be one of the reasons for difficulty in cannulating. And to prevent this ischemic limb, so distal cannulas are usually placed to perfuse the distal part of the limb. And distal cannula is usually 4 to 5 French. One is placed to perfuse the artery so that one can avoid the distal ischemia that tends to set in. And now it's a standard of care. The distal cannulas are put in to prevent the limb ischemia, especially in the VA ECMO. So as you see, these are the distal cannula. This is an antegrade sort of a cannula that is put in to prevent the distal ischemia or the limb ischemia. And in any patients who is on a VA ECMO or limb ischemia, so serial Doppler is something one need to keep in mind to look for any early signs of ischemia that may be setting in. And these patients are at a risk of developing compartment syndrome. It is desirable that distal perfusion pressure is more than 50 millimeter mercury, or distal saturation should be more than 94%. So these are some of the surveillance measures that one can put in place. Serial Doppler is something one should contemplate to prevent these limb ischemias that may be setting in due to arterial thrombosis or limb ischemia. If you have a non-invasive near-infrared spectroscopy, it should be more than 40. So these are the values that one can keep an eye on to prevent the distal ischemia, especially if someone is on VA ECMO. So other vascular complications, just put in a pictorial format. So there can be posterior wall rupture during cannulation, or there can be AV fistula. So these complications are intuitive for most intensivists, even when you are putting dialysis catheter or any catheter where repeated punctures, it can lead to arteriovenous fistulas, or there can be aneurysms, arterial aneurysms when there is multiple puncture attempts. There can be dissection of the uh, artery that can happen, especially in atherosclerotic patients, and groin infections, or at the site of insertion, they are at a risk of infection. So these are some of the typical vascular complications that one would see when you're handling the arteries and the veins. So, so just remember this picture. So these are some of the common complications that one can encounter. So when it comes to, so those are about the cannula and the cannula related complications. Then there are circuit related complications. So there can be displacement or sort of a disruption of these cannulas that can happen, or there can be bleeding of the or the plasma leakage or the bleeding that can happen because of the loss of integrity of these circuits that can happen. So nowadays, the most of these circuits are made up of polymethylene pentane, which are more of superior quality, and disruption of these circuits are seldom happens because of this material. And centrifugal pumps also are one of the reasons that most of the circuit integrity is well maintained. And power outage is something that one needs to bear in mind, because mechanical failure is something that can happen and that can be disastrous for the patient, especially someone is on ECMO. So battery backup, and one has to be cognizant that power outage does not happen. And backup of ECMO circuits is very much needed, because if there is disruption of the ECMO circuit, or if there is a failure of the oxygenator, failure of the centrifugal pump, so one needs to have a backup of these machinery so that the disastrous complications could be averted. And it's most important to have a backup experienced perfusionist or a personnel who can recognize and identify this mechanical failure. And perfusionists are the key. So a well-experienced perfusionist is someone who will have a very diligent and vigilant sort of an observation on these aspects. And their role is pivotal in averting such mishaps. especially something to do with oxygenator or the centrifugal pump or with regards to your circuits and so on and so forth. So bleeding, as I said, bleeding is an important complication. So it is shown that ECMO patients have a very smoldering sort of a inflammatory process on the background. So there is a low grade inflammation because of the extracorporeal circulation. So these patients have a smoldering sort of an inflammatory process on the background, and it is reflected with increase in the SOFA score, increase in the SAP score in these patients. And it is shown in one of the studies in 321 patients on ECMO, 123 patients, about 49% of them had bleeding, and this had a direct correlation with the ICU mortality of up to 46%. So around 10 to 30% is what has been referenced in literature with regards to the bleeding complications that happen in ICU. But as I already said, in ECMO, there is always a trade-off between the bleeding and the prothrombotic state. So one needs to have a fine balance between avoiding bleeding, at the same time avoiding prothrombotic state. They are at a risk of developing venous thrombosis and arterial thrombosis, and they need to be on anticoagulation heparin to prevent this thrombosis. So this is something one needs to keep in mind. So as much as they are at a risk of developing thrombosis, they are at the same risk of developing bleeding, and that is the fine balance that one needs to attain when someone is on ECMO. So the commonest bleeding sites are usually the site of cannulation. So wherever you are putting in the needle, so they become the site for bleeding. And but bleeding can happen, innocuous bleeding can happen anywhere. And the IC bleeds or intracranial bleed is a dreaded complication. Very often, because the VV ECMO, when patient is on VV ECMO, they have a diseased lung, they have ARDS lung, and they are at a higher risk of pulmonary hemorrhage, and airway bleed is found to be very common, and they can have GI hemorrhage. So hemorrhage can happen anywhere, but these are the commoner sites of hemorrhage. And this hemorrhage invariably is compounded because of over anticoagulation. And very often these patients tend to have thrombocytopenia, and there is a inherent platelet dysfunction that sets in patients who are on ECMO. And thrombocytopenia can be hit related, or the sheer fact that they are on a extracorporeal circulation, there is a fall in the platelet count. And as I already mentioned, they have acquired von Willebrand deficiency that tends in. So all these are some of the reasons which puts them at a higher risk for bleeding. So inappropriate anticoagulation, thrombocytopenia, and platelet dysfunction, and von Willebrand deficiency, acquired von Willebrand. All these are some of the reasons for bleeding. And this is the data that came from the Austrian study. As you see, the bleeding typically happens at the ECMO cannula site and catheter site. The second commonest is operating site. Third is lungs. As I said, because lungs are already affected, they are at a higher bleed. And intracranial hemorrhage constitutes in fourth to fifth place. So typically it can happen anywhere. Commonest is always the cannula sites, surgical sites, and lung and airway. So that is what is reflected in most of the data. And when you look at the ELSO data, so this is the most recent data that has come out in 2022. And if you see this data, and as I've already made a mention, so the number of patients who are at a risk of thrombosis and bleeding are pretty much similar. As you see, 54.9% of the patients had a risk of thrombosis, 45.1% had bleeding. And the total events they looked at, ELSO is the largest registry, 4,840 patients they looked at. And the risk of thrombosis seems to be little more than the risk of bleeding. And if you see, most of the thrombosis is due to the circuit clotting, followed by the pump failure and hemolysis. So these are the three important reasons for thrombosis. And if you look at the ELSO registry, the bleeding again is very common at the cannula site, followed by the surgical site, followed by GI bleed and pulmonary hemorrhage. So if you can remember this, these are the common sites to be looked at for the sites of bleeding: cannula sites, lung hemorrhage, airway hemorrhage, and surgical site bleed. Thrombosis more commonly look into the circuits, because circuits are the common site of thrombosis, and hemolysis is the second or third more common cause. So as you see, this is just a figurative representation. As much as there is a procoagulant sort of a mechanism that is activated, the equal amount of anticoagulation effect also is triggered, and there has to be a fine balance between these two, is what is depicted in this. And anticoagulation, so the heparin is the commonly used sort of an anticoagulation. So one has to maintain adequate heparinization, and ACT is something that you can monitor and try to keep it around I think this is again there is now the school of thought that one has to keep the ACT little lower. So 180, what they're telling 160 to 180. Some centers talk about 180 to 200. So one has to calibrate and maintain adequate ACT to make sure that there is enough flow without causing thrombosis. And thrombocytopenia can be due to heparin-induced thrombotic thrombocytopenia, or there is inherent platelet dysfunction that happens when they're on ECMO circuit due to the deficiency of glycoprotein 1b alpha and glycoprotein 4. So, because of this deficiency, just because of the fact they are on ECMO, there can have a platelet dysfunction due to deficiency of this glycoprotein that can set in. And this is a study that came from the Dutch group, which has extensively looked at all the studies. 14 studies they have looked at to capture the sort of prevalence or occurrence of thrombocytopenia. And this systematic review showed thrombocytopenia occurs in 21% of the patients in ECMO. And they have stratified it in different ECMOs. In VV ECMO, they have looked at 4 studies which has reported thrombocytopenia, and the occurrence rate is 25.4%. VA ECMO in 6 studies, the occurrence rate of thrombocytopenia is 23.1%. Actually, if you look at the hit, which is reported in 12 studies, only 3.7%. So the commonest cause is the fact that an ECMO itself is the cause for thrombocytopenia, and heparin-induced comes around 3.7. So this is the sort of data we have with regards to. So what you need to remember is thrombocytopenia as a matter of fact, can occur in someone who is on ECMO, and there is a platelet dysfunction also that sets in. So these are the two things. Von Willebrand deficiency also sets in, and anticoagulation. These are the commoner sort of a reasons that can cause the bleed in the patients with ECMO. Just a bit of mention on von Willebrand. This is how the von Willebrand factor looks. Just again, the fact that there are an extracorporeal circulation, so there is breakage of this von Willebrand factor, and it is shown to be found in most patients for an ECMO, and it is very under recognized because there's no way you can determine von Willebrand activity, and many of these patients have von Willebrand deficiency. And this is shown to happen because of reduced activity due to breakage of these multimer bands, because as you see, it looks like a multi-banded structure, and these get broken off, and there is a deficient von Willebrand activity that tends to happen. And when this is there as a risk and the treatment is not plasma, you need to give cryoprecipitate, because cryoprecipitate is the one which has von Willebrand factor, factor 8, and fibrinogen. So these are the components that are present in cryoprecipitate. So when ECMO patient has a bleed, one needs to think of cryoprecipitate as a replacement, suspecting that there could be von Willebrand deficiency, which tends to occur in most patients. And in India, we do not have von Willebrand factor as a recombinant sort of an drug. But in US, von Willebrand is available as a recombinant drug. And possibly we should look at having this in India as a replacement, especially in patients with ECMO if they're bleeding. So this is something one needs to keep in mind. So this is an interesting thing. Hemolysis is touted as one of the important prognostic marker, and in one of the studies, the plasma-free hemoglobin of more than 50 milligrams per deciliter, less than 24 hours of cannulation, is a marker. So that came from this study. It's a good marker that hemolysis has set in. Why it is important? Because the studies have shown the hemolysis occur very early on. So it's a cascade that tends to happen within 24 hours or 24 hours after cannulation. So measuring plasma-free hemoglobin and having it, if it is more than 50 milligram per deciliter, it identifies the patients who are at a risk of hemolysis, and this had a direct bearing on the mortality, because in this study they showed that if patient have this hemolysis that set in, the odds of mortality was 3.4, and it was significant. So, but the plasma-free hemoglobin measurement is something that is also diagnostically challenging. So we are not aware where it is done, because one needs to do spectroscopy to do this plasma-free hemoglobin. And when plasma-free hemoglobin is more than 50, so there's more von Willebrand factor, it causes platelet sort of a aggregation. And this platelet aggregation leads to the fibrin clot, and there is more consumptive coagulopathy, and the DIC sets in. So this is the sort of a conundrum sort of an effect that happens in patients who have hemolysis. So when there is an ongoing hemolysis, there's more consumptive coagulopathy, there's more fibrin clots that are formed, and they have this smoldering DIC. and this has a bearing on their outcome and mortality. So hemolysis is something that one needs to keep in mind. So von Willebrand deficiency and hemolysis are something which are under recognized, and possibly they tend to occur little early on, and that has a significant bearing on the outcome of these ECMO patients. So, with regards to troubleshooting, there is something called shattering of circuit that happens. So, this is something which can happen because of blood flow. So, when there is inadequate preload and there is not enough blood that is able to be drawn from the venous on the venous cannula. So, and you have a RPM which is set at a high level. So, there is a huge negative pressure that is created that leads to swinging movement of this venous cannula site or the venous circuit site, which is also called kicking, swinging, or rattling. Because there is a supply demand mismatch. So basically, you have a centrifugal pump which is running at some RPM, which is meant to draw the blood, but there's not enough blood being drawn from the venous circulation due to reduction in the preload. So there is a sort of a negative suction that is created, which leads to movement of the venous circuit, and this is called chattering or kicking or rattling. It is like a fire hose which is left loose on the floor. So you have a water pipe left on the floor with huge pressure. It keeps moving like a snake. So it won't move so randomly, but whatever movement you see on the venous sort of a circuit is called chattering. So how do you fix this chattering? So the solution is, because there is reduction in the preload, there's not enough blood that is being able to sucked out. So one has to give additional preload, and that's what we do when there is this chattering that happens. And one has to look if there is any kinking of the cannulas, because kinking is a common sort of a reason for this chattering that can happen. So if there is kinking or malposition of the cannula, that needs to be addressed, or there can be hemorrhage at the cannula side that can be leading to the increased resistance and chattering. So, and hemorrhage is something that one needs to keep. Or you need to reduce the speed of the centrifugal pump because it is running at a high speed, but there is not enough blood to be drawn from the venous, and that's what leads to chattering. So you have to reduce the RPM speed, and hemorrhage if there that you need to address, because that may be leading to increased resistance and the chattering. Or sometimes increase in the intrathoracic pressure or intra-abdominal pressure again can lead to some sort of a resistance in the flow from the venous end, and that also can lead to generation of this negative pressure, which can lead to chattering. So this is a common thing one needs to keep in mind, and perfusionists are really good in trying to look into this and identifying this, and the immediate step that one can do is to reduce the RPM, give preload, and check for any kinking or malposition. So this is just a video to show how the chattering. If you see this, there is this fine movement. You can see that very carefully. There is a fine movement of the venous cannula that is happening. So you can see that movement. So it is not like a hose pipe on the floor. It's a gentle sort of a movement that is happening. So that is chattering, where there is a negative suction that is created. So that's about the circuit related. So we'll just talk about neurological complications. So brain death is something that is shown to occur, intracerebral hemorrhage. So as I said, the trade-off is between preventing thrombosis and the bleeding. So is the case in intracranial. There can be intracranial hemorrhage, or there can be stroke, and seizures is also something that can occur in brain death. And VA ECMO in this particular study, the neurological complications is put as 21%. And another reason for neurological complications in someone who is on VA ECMO is differential hypoxemia, which is called Harlequin syndrome. So a neurological complication can happen. So one has to be very cautious in looking into making sure there are no air bubbles within the circuit, because that can lead to embolism. Or one has to keep a close eye on any microthrombi, because this also can lead to stroke. And some of the risk factors for neurological complications is hypotension or hypertension, or hypo or hyperglycemia, or hyperthermia, or metabolic acidosis and electrolytes. So these are some of the triggers for worsening of the neurological complications, or triggers for neurological complications. And when someone is initiated on BV ECMO, especially with PCO2s are very high, because high CO2 is one of the reasons that ECMOs are initiated in patients with ARDS. So when someone has a say high CO2 of 90 and you initiate an ECMO, and there is a sudden drop in the CO2 from 90 to 35, so this can cause severe vasospasm because of the sudden reduction of CO2, cerebral vasospasm occurs, and this can lead to the stroke. So this is something one needs to. So sudden reduction of carbon dioxide can lead to vasospasm leading to the stroke, and that is something one needs to keep in mind. And VECMO, there can be differential hypoxemia, which I'll talk about, which is also one of the reasons for neurological complication, or there is a low pulsatile flow that can happen in ECPR. That is also one of the reasons for neurological complication. And HEB is hypoxic ischemic brain injury that tends to happen in ECMO patients. And the factors for that is machine-related factors, which I mentioned. And as I said, there is a low-grade inflammation. There's a lot of microcirculatory dysfunction. There's microthrombi formation, which act as a trigger for hypoxic ischemic brain injury. And the differential hypoxemia that sets in due to Harlequin syndrome. And there can be loss of autoregulation in the brain and global hypoxia. So these are some of the broad triggers for hypoxic ischemic brain injury. So machine-related factors, microthrombi and microcirculatory dysfunction, and differential hypoxemia, which I'll talk about. And there is a loss of autoregulation and hypoxemia, global hypoxemia. All this lead to, and as I said, ECMO is a low-grade inflammatory process. There is some sort of a cytokine activity leading to prothrombotic state, and there is loss of pulsatile flow. All these put them at a much higher risk of forming microthrombi and lead to hypoxic ischemic brain injury. So this is the sort of a vicious conundrum that tends to happen, which puts them at a higher risk for neurological dysfunction. So just talking about VA ECMO. VA ECMO, the risk for again they are at a higher risk of stroke, which can be ischemic stroke or intracerebral hemorrhage, and the risk is 4 to 7% of them can develop stroke. And ischemic stroke is a late complication, so it is terribly important that anticoagulation is well maintained and surveillance of the circuit. Why we need to do the surveillance? To look for any microthrombi formation or clots or air bubbles within the circuit, because all this put them at a higher risk of developing stroke. As much as they are at risk of a stroke, they can have intracranial bleed. Intracranial bleeds are the early complications in VECMO. Ischemic strokes are the late complications in VECMO. And IC bleeds are worse than ischemic stroke. The mortality is up to 80 to 90%. And as I said, there should be a good balance in preventing this thrombosis and preventing the bleed. And that is the whole art and science of ECMO. And the factors for IC bleed, as we have already elucidated, it is thrombocytopenia, and IC bleeds are found to be more commoner in the female gender. And someone who is on a renal replacement therapy or multi-organ, they are at a risk of ischemic stroke or machine failure. So if there is a machine malfunction or ECMO is becoming dysfunctional, so all these, because there is stasis of the blood, and whenever there is a stasis, they are at a much higher risk of developing ischemic stroke. So it's very important to have a backup sort of a plan with regards to any mechanical failure that can happen on the ECMO. So these are some of the risks for stroke. So differential hypoxemia or the Harlequin syndrome is something which is seen uniquely in patients with VA ECMO. The VA ECMO is put in hemodynamically unstable patients. VV ECMO is to rest the lung. In VA ECMO is done in a patient where cardiac dysfunction is there to rest the heart. So our whole intent is to perfuse with the pure oxygenated blood into the arterial circulation. And in the face of heart function improving, so there is a mixture of oxygenated blood along with the deoxygenated blood that tends to happen, which leads to differential hypoxemia. And the location where this mixing of the pure oxygenated blood with deoxygenated blood happens depends on the intrinsic cardiac function. And this typically happens in the phase of improving cardiac function, because when the heart is at rest, the whole perfusion is happening with the super oxygenated blood. But when the heart function is improving, so this typically happens in the phase of recovering cardiac function. Cardiac function is improving, but there is still pulmonary insufficiency. The typical scenario is you have a weak heart with some sort of a lung pathology and pulmonary insufficiency is there. So there is no effective oxygenation that is happening in the lung. That is when the deoxygenated blood is mixed with the oxygenated blood. So the diagnosis is by doing a arterial blood gas from the right radial artery, because right radial artery is a reflection of the ejection of blood from the innominate artery, and that is where your first sort of an indication of differential hypoxemia can be identified. So doing an arterial blood gas from the right radial artery which is a reflection of ejection of blood from the aortic arch to the innominate artery, is reflected. That is where it shows differential hypoxemia is set in. So this is just a pictorial representation. If your heart is fully rested, then it means your VA ECMO is oxygenating with a pure oxygenated blood. But as the heart function improves and the heart is pumping out the blood into the lungs, and where you need to have adequate oxygenation coming into the left atrium, that is where, in the phase of improving cardiac function, the mixture of pure oxygenated blood with the deoxygenated blood happens, which leads to differential hypoxemia, which can be recognized by doing a blood gas. So it tends to happen in the phase of improving cardiac function in VA ECMO. If you remember that, and pictorially you remember this figure, so as you see, cardiac function is zero, there is no differential hypoxemia. Cardiac function is very low, it is not pumping any blood, so there is no differential hypoxemia. Here, cardiac function is improved because ECMO, as you would know, is a bridge for cardiac sort of a procedures, or where there is an MI and so on and so forth, where or cardiogenic shock to do it as a bridge. But if cardiac function, once it starts improving after your revascularization, then the heart starts pumping blood, and that blood needs to get adequately oxygenated in lungs and come back. But if there is inadequate oxygenation, so this gets mixed with this pure oxygenated blood that is coming from the arterial cannula, and that leads to differential hypoxemia. So typically, if you remember, it happens in the phase of recovering cardiac function with a lung pathology still prevailing. That is when the if lung is very pristine, differential hypoxemia may not occur. If there is a pulmonary insufficiency and there is no adequate oxygenation happening in the lung, but heart is improving and patient is on VA ECMO, that is when differential hypoxemia can set in. If you remember that, that should be good enough. And how do you address this? So because there is a there is a mixing of pure oxygenated blood with the deoxygenated, increasing the flow of of the return of the cannula with the oxygenated blood. So increasing the oxygenated blood from ECMO is a solution for this. Or if this is not helping, you need to put additional cannula into the right internal jugular vein and reroute the oxygenated blood into the right internal jugular vein. So which is called VAV. So it is a veno-arterious venous ECMO. So which means there is one cannula which is draining from the femoral vein and pushing back into the femoral artery, and you are pushing back the oxygenated blood again into the right IJV to prevent this deoxygenated blood mixing. So this is the procedure one has to do to address the uh, differential hypoxemia. So another complication that happens in VA ECMO is left ventricular distension, and this typically happens in VA ECMO. So what really happens is this LV distension typically happens in patients with a very low ejection fraction of, if it is less than 15 to 20%, where heart is unable to pump the blood. But this ECMO, what you're doing, you're taking the blood from the femoral vein, oxygenating and pushing it back into the arterial circulation. So there is increase in the afterload because you're pushing the blood in the face of very poor cardiac function. So there is increase in the afterload and the heart function is very low. And how does the heart respond? It responds with your LV dilatation or LV distension. And there is an LA distension. So LV also gets distended, LA also gets distended, and there is a bulging of the mitral, upward bulging of the mitral valve. And this leads to the congestion of the lungs and pulmonary edema. So this is typically happens in a patient with a very poor LV function. You are trying to pushing in the oxygenated blood into the arterial circulation, which increases the afterload, which heart is unable to cope, and it responds by LV dilatation and LA dilatation and upward bulging of the mitral valve, which leads to pulmonary congestion. So the simplest solution for this is putting them on balloon pump, and this is the simplest way. If this does not work, then you have to decompress of the LV by the LV vent. So you need to put an LV vent to decompress the LV distension, or one has to put interatrial septostomy. So one needs to create a hole between the atria to decompress the pressure on the LA and LV. So these are all procedures possibly which needs collaborative effort from the cardiothoracic surgeons to help us with these sort of a situation. So VA ECMO is a collaborative work between intensivists and the cardiothoracic surgeons. So VV ECMO is more for intensivists. So this is what one can keep in mind. So just moving out of the heart, renal. So acute kidney injury tends to occur in 60% of the patients with VA ECMO, and it has a direct bearing on ICU mortality. 46% of the patients who develop AKI need CRRT, and they have looked at early versus late CRRT. There is no difference. So the risk factor for AKI is hypotension, hemolysis because of hemoglobinuria and the tubules getting clogged in the kidney is the risk. And the thrombus causing renal artery ischemia is one of the important reasons that acute kidney injury can set in, or there can be renin angiotensin aldosterone dysfunction. So these are some of the risks for patients developing AKI. Any ECMO patient's whole effort is to prevent any other organ dysfunction. If there is renal dysfunction, if there is hemolysis, if there is DIC, if there is neurological dysfunction, all these worsen the outcome in ECMO and increase their morbidity and mortality. So coming to last one or two slides, so infections, I'm sure all intensivists are experts in this. ECMO patients are at a very high risk of infections. The ELSO registry suggests that 21% of the patients with ECMO have increased risk of infections or they do develop infections. Bacteremia tends to happen in 3 to 18%, and pneumonias tend to happen in 24.4 per 100 ECMO days is the prevalence rate from ELSO registry. And the attributable mortality is 38 to 63% is the mortality when they develop bacteremia or pneumonias in patients who are on ECMO. And pre-cannulation SOFA score is a good predictor of the patients who can develop infections. And infections are found to be more common in VA ECMO than in VV ECMO. And longer the patient is on ECMO, higher is the risk of infection. I'm sure it is quite intuitive for all of us that longer the duration of ECMO or longer the duration of ventilation, we know they are at a higher risk of infection. And with regards to antibiotic prophylaxis, there is no evidence for routine prophylaxis, but I'm sure every intensivist can put their hand on heart that any patients on ECMO are on multiple antibiotics, but at least try to be being rational with the use of antibiotics. And definitely when there are no symptoms, one need not put them on prophylactic antibiotics. So just a last slide on recirculation. So what are you doing in ECMO? Basically, you're drawing the blood from the venous, putting into the pump, oxygenating it, and pushing it back into the heart. But here, if your pump speed is very high, or if your position of catheter is erroneous, then you will have this superoxygenated blood that is coming into the RA and RV, pulling back into the venous circulation. That is called recirculation. As you see, it should be blue. So because your superoxygenated blood is getting mixed with the drawing cannula from the venous side. So there can be sort of a recirculation that how do we recognize this or you have to identify this recirculation. So you had to look at the central venous oxygen levels from the left internal jugular vein away from where you're having the having to push the superoxygenated blood. So you check the central venous oxygen here on the left internal jugular vein, and you take the central venous oxygen levels at the pre-membrane because you are before you push the patient from into the pump, and these both have to be same because if this is very high, if your venous oxygen saturation before the pump is high, then you know recirculation is happening because this is meant to be venous blood. So this venous oxygen level should be same as the left internal. But if this venous oxygen levels are higher than the left internal jugular, then you know that superoxygenated blood is getting recirculated. So what is the solution for that? So you have to reduce the flow because your flow rate, your RPM is high, there is remixing. Or most importantly, you may have to reposition the catheters because if these return cannula and the drainage cannula are very close to each other, so that may be one of the reason why recirculation. So one has to reposition the cannula, and ideally they need to be repositioned under the fluoroscopic guidance if there is this sort of a recirculation that is happening. So this is about it. So that is about all the complications. So when you look at the summary, so in ECMO, the complications are just about too many, but the way you can divide is patient factors, all related to the patient, machine, and the circuit factors. So, and the whole major complications one needs to put in their mind or keep in the front of their mind is having a balance between prothrombotic state and bleeding. So one needs to make sure that you are adequately anticoagulation, there is no thrombosis, at the same time prevent bleed because these are the commonest complications. And the other patient-related complications are hypoxic ischemic brain injury and von Willebrand deficiency, thrombocytopenia, hemolysis. These are some things to keep an eye on because these have a direct bearing on worse outcomes on ECMO. and ECMO patients are at increased risk of infections and take all measures to prevent AKI because if they develop AKI needing CRRT, it worsens their outcome. So these are a simplistic sort of a schematic representation of patient factors that typically happens in ECMO and the machine factors, which we all discussed. Perfusionists are very good, so be in constant collaboration or communication with perfusionists because they are the ones who keep a very close vigil on all these machine factors and the circuit factors. And in circuit, most important is to ensure that a careful examination or surveillance to having any clots in the circuit or any chattering that is happening or any air embolism. All these are the simple things that one needs to keep a close eye. And obviously, good maintenance of these machine factors are also important to prevent any devastating complications. So that's about the whole complications. So I request all our listeners to attend and be a part of this academic celebration JIC, which is a signature event that's happening in our region on 17th to 18th October are the workshops and 18th to 20th is the conference. So request all the listeners to submit your valuable work to Journal of Acute Care. So you can visit my website to rehead to this lecture. So thank you. Thank you, Manoj.